Today's topic is benign lesion of vulva and vagina. Benign lesions of vulva and vagina. Vulvar epithelial disorder, vulvar ulcer, vulvar cyst, benign tumor of vulva, that is vulvar endometriosis, vaginal wall cyst, that is maybe Gardner cyst or inclusion cyst, vulvar pain syndrome, vulvar epithelial disorder. These are non-neoplastic epithelial disorder of vulval skin and mucosa. They classified according to International Society for Study of Vulvovaginal Disease. VIN lesion have been excluded from the classification. Etiology: there could be trauma, autoimmune allergy, irritation, nutritional deficiency of folic acid, vitamin B12, riboflavin, achlorhydria. It could be infection because of fungus, metabolic, autoimmune disorder, thyroid, pernicious anemia, diabetes. Personal or family history of atopic conditions like asthma, eczema, hay fever. Drug like beta blocker, ACE inhibitor, and allergen. According to the ISSBD classification of vulvar dermatosis, they are spongiotic pattern and atopic dermatitis, allergic or contact dermatitis, irritate contact dermatitis. Acanthotic pattern includes psoriasis, lichen simplex chronicus. Lichenoid pattern include lichen sclerosis, lichen planus. Dermal homogenization sclerosis pattern include lichen sclerosis. Vesiculobullous pattern include pemphigus linear IgA disease. Acantholytic pattern include Henle disease, Diarrhea disease, papular genitocruel acantholysis, granulomatous pattern, Crohn disease, Malkeroson-Rosenthal syndrome. Vasculopathic pattern includes aphthous ulcer, Behçet's disease, plasma cell vulvitis. Then comes the diagnosis of vulval epithelial disorder. History is essential. Symptoms can include itching, irritation, pain, vulval discharge, can be associated with symptoms of oral, ocular, intestinal membranes related with the menstruation or associated with cervical smear or cell abnormality. Sexual history, there may be dyspareunia, any discharge, STI, HIV, use of medication to cause allergy. Others may include smoking, alcohol. Examination, during examination through colposcope, skin thickening, ulceration, discharge, and nodularity can be seen. Specific anatomical site for examination: mons pubis, labia majora, labia minora, inner labial sulci, interlabial sulci, clitoris, vestibule, perianal skin, vagina, cervix, inspection of oral mucosa, eye, scalp. Biopsy is required if failed to respond to treatment. Site of biopsy, margin of cracks and fissure. Lichen sclerosis. It is an autoimmune mediated dermatosis. It occurs mostly in the menopausal woman, childhood, but in that case, it resolves after menarche. Distribution of the lesion. Entire vulva is involved. Lesion encircle the vestibule. It is usually bilateral and symmetrical in figure of 8 distribution. It does not involve the vestibule or extend in the vagina and canal. It may extend to perineum or may include the thigh. It may also affect the other part of the body, that is trunk and limb. Pathophysiology: autoimmune disorder like diabetes, achlorhydria, pernicious anemia, cell associated in 20 to 30% cases. Level of dihydrotestosterone and androstenedione are low. Clinical feature: the pruritus, itching is there, soreness. Dyspareunia is due to stenosis of vulvar outlet, sleeplessness, dysuria, retention of urine, scratching, result in the subepithelial hemorrhage. This is a diagrammatic representation of vulvar lichen sclerosis. Histology of the lichen sclerosis, showing atrophic and flattened epithelium with loss of reticulate edges. Diagnosis is confirmed by the biopsy, and biopsy can be taken by the punch biopsy first time under local anesthesia. Monser solution is applied to control the bleeding. Ferric subsulfate Risk of malignancy is very less, that is less than 5%. Treatment, patient education, avoid chemical or mechanical irritant on vulvar skin, topical corticosteroid, phototherapy, lesion resistant to steroid, tacrolimus, and can be used. Surgery may include excision, perineoplasty. Lichen planus. After skin and oral genital mucosa, age 30 60 years, T cell autoimmunity directed against the basal keratinocytes. Three types of lesions are there: erosive one, papillosquamous one, hypertrophic. Clinical feature: vulvovaginal pruritus, burning pain, dyspareunia, postcoital bleeding, vaginal lesion can produce adhesion. Treatment includes the topical corticosteroid, usually clobetasol is given, vagina savosi containing the 25 milligram hydrocortisone or surgical adhesive system. Risk of malignancy is very low. Lichen simplex chronicus. Severe intractable pruritus, especially at the night, involve the labia majora, mons pubis, and inner thigh. Erythema, swelling, and lichenification. Investigation: look for the thyroid dysfunction, diabetes, STI. Skin biopsy needed for the confirmation. Treatment: avoid irritant, antihistamine, topical steroid may be given suppository. Extramammary Paget disease. Extramammary Paget disease of vulva is rare condition seen in the postmenopausal women present with the pruritus. On examination, florid eczema with the erythema and excoriation. It can be associated with the underlying an adenocarcinoma. Treatment is surgical excision. Photodynamic therapy and topical imiquimose have been used. Vulval Crohn disease. Crohn disease affecting the intestine may involve the vulva in later stage of disease. Vulval lesion commonly metastatic, typically granulomatous inflammation. It affects the inguinal genital interlabial fold. Vulva is swollen, edematous with granuloma ulceration there. It may be classical knife cut fissure in the interlabial sulci. Treatment include antibiotics, topical steroid, oral TNF alpha blocker. Psoriasis, multifactorial disease, T cell mediated autoimmune disease. The lesions are present on the labia majora, genitocranial fold, and in inguinal folds. Skin changes, silvery scale appearance, and bleeding on the gentle skin. Vulvar psoriasis may resemble candidiasis. Psoriasis usually does not involve the vaginal mucosa. Treatment include emollients, topical corticosteroid, calcicotropin. Relation with the malignancy. About 50% of invasive carcinoma vulva arise in the area of chronic vulvar epithelial disorders. Biopsy is required. Skin biopsy is not needed when a diagnosis can be done on clinical examination. Required if failed to respond the treatment. Site of biopsy are from the margin of cracks and fissure. Treatment of vulval epithelial disorder. Patient should avoid deodorant, spermicide, and perfume brigade, and non-irritant soaps should be used in area dried carefully without much rubbing. A patient should use either cotton underwear or nothing at all. Histopathological diagnosis has made by biopsy in prior to institution and therapy. This is a picture showing the vulvar dystrophy associated with the malignancy. Vulval ulcer. Vulval ulcer are predominantly due to sexually transmitted disease. Malignant ulcer are also rare. Crohn disease, it affects primarily the intestine and may involve in the vulva. Late stage of disease is about 25% of cases. Ulcer look like granulomatous, like knife cut in the skin. Now, there is Behçet disease. This is a rare chronic inflammatory disease characterized by recurrent oral and genital ulcer, which with ocular ulcer. It may be manifestation of underlying autoimmune process. Monoarticular arthritis may also be associated. Vulvar ulceration may be extensive, leaving behind dense scar after healing. Treatment it includes topical and systemic corticosteroids, systemic immunosuppressants. So this is a tabular form of ulcers of vulvar, STD-related, idiopathic, tuberculosis, malignancy-related, systemic disease-related, or so they five category they divide, and STD-related could be syphilis, herpes genital, synchroid, granuloma inguine, lymphogranuloma, venereal. Idiopathic could be wasted aphthous, tubercular. Malignancy may be primary or secondary. Systemic disease related SLE, Crohn disease, lichen planus, lichen sclerosus, Sjögren's syndrome. So vulval ulcer because of leukemia rarely may cause nodular infiltration. Dermatological disorder like seen in E. disseminated lupus erythematosus may cause recurrent ulceration of the vulva. Acantha's nigra characterized by velvety to warty, brown to black pigmentation, side flexure of neck, axilla genitopure, skin thickness due to insulin resistance due to hyperinsulinemia cause dermal fibroblast proliferation. Treatment usually weight loss, metformin, topical keratiolytic. Vitiligo. Skin pigmentation, loss of melanocyte in the genital region. It may involve other part of the body. Patchy and symmetric lesions, autoimmune disorder that destroy the melanocytes. Narrow or band, ultraviolet B, phototherapy, excimer laser therapy, and topical immunomodulators. Topical and systemic corticosteroids are used for the relief of the symptoms. Then comes the writer's disease. It is the ulceration again of the vulva, also infecting the bowel. It manifests arthritis, uveitis, skin lesion. Aphthous ulcer. It is seen on the oral cavity, also on the vulvar and vaginal surfaces. Ulcers are painful, etiology, infection, stress, nutritional deficiency like zinc, vitamin B12, folic acid, iron, and vulval manifestation of the systemic diseases. It includes dermatological disorder like contact dermatitis, psoriasis, ulceration due to DLA, vulvar ulceration or deposit due to leukemia, acanthosis nigricans, chronic vulvar vaginal candidiasis, Behçet syndrome, Sjogren syndrome. Vulvar cyst. The various types of vulvar cyst it include Bartholin cyst, sebaceous cyst, cyst of canal or neck, inguinolabial hernia. Sebaceous cysts. These are the usually multiple and formed by the accumulation of sebaceous matter due to occlusion of the duct. They are located in the labia majora. If in fact treatment is done by antibiotic surgical drainage. Cyst of canal of neck. The part of processus vaginal which accompanied the round urine got obliterated prior to birth may persist to form the cyst. Invariably occupies the anterior part of the labia majora. Inguinolabial hernia. When the entire processus vaginal is pitted, there may be herniation of abdominal content along the tract. The hernia may limit it to inguinal canal or may extend up to the anterior part of the labia major. Content of the sac may be intestine or mentum. The swelling is reducible. Vulval varicosity. These are the mat predominantly during the pregnancy, subside following the delivery. Support pad or tight T bandage is the thing. If it is fails, then sclerosing agent is given or high ligature of long sickness may be elephantiasis vulva. It is mainly due to consequence of lymphatic obstruction of microfilary. Plastic surgery may be tried to restore the anatomy. Ectopic breast tissue rarely present in the embryological milk line that extend from axilla to mons pubis. The breast tissue may be harmonized and may enlarge during pregnancy. Benign tumors of vulva. Fibroma, lipoma, neurofibroma. These are all benign tumors of varying size. Fibroma is the most common benign solid tumor of the vulva. It arises from deeper connective tissue of the labia majora dermatofibroma. Vulval fibroma grows slowly. It may small, but malignant change is very low. Surgical removal is necessary as they produce discomfort. Heteroadenoma. Heteroadenoma arises from the side glands, usually located in the anterior part of the labia majora, and it rarely exceeds 1 centimeter. It is benign lesion of, but it is reddish look and complex adenomatous pattern on the histology. It may be confused with adenocarcinoma. Simply adequate and biopsy is adequate. Vulvar endometriosis. Vulvar endometriosis is usually found at the site of obstetric laceration, episiotomy area of excite Bartholin duct cyst. It may appear as a swelling near the insertion of the round ligament in the anterior part of the labia majora. It may be associated with pelvic endometriosis. It presents in the limited only to reproductive period and become enlarged tender during menstruation. Treatment is surgical excision and confirmed by the biopsy. Vulvar, this is a picture showing vulvar fibroma and vulvar lipoma. Vaginal wall cyst. So vaginal cyst is rare. Gardner cyst, commonest type found Gardner cyst and epithelial inclusion cyst. Gardner cyst. Gardner cyst duct is usually situated anterolateral wall of the vagina. Epithelium is low columnar, secrete mucinous material which part pent up to form the cyst. Treatment is by surgical excision. Inclusion cyst. Common vulvar cysts are epidermal inclusion cyst or sebaceous cyst. They are located beneath the epidermis in the anterior half of the labia majora. Alternative histology is the embryological remnant occlusion of pilocevice duct of side gland. The vaginal epithelium includes cysts arise from the epithelium buried under the mucosa. Treatment is symptomatic case is by the surgical excision. So this is a picture showing the Gardner duct cyst, the vaginal wall inclusion cyst. Vulval pain syndrome. So vulval pain syndrome may be burning, stinging, irritation. It may produce several episodes ulcer, vulval dermatosis, herpes genitalia, pudendal and genitofemoral nerve neuralgia, vulvodynia, vulval vestibulitis syndrome, referred pain from the urethra or vagina, psychological. Vulvodynia. It is severe pain process, socially debilitating disease where infection, invasive disease, or inflammation excluded. It is characterized by burning sensation over the vulva. It often seen in the perimenopausal or postmenopausal when exact etiology is not known. Clinical exam does not reveal any abnormality. In many cases, treatment include TCA 60 milligram per day for the 3 to 6 months, gabapentin, carbamazepine, antifungal therapy, surgical resection of the vestibule. Vulval vestibulitis syndrome. It is a condition of hyperesthesia pain without any stimuli is characterized by pain around the duct of bathroom gland and the introitus. There may be superficial dyspareunia and vestibular tenderness on touch. Treatment of vulval pain syndrome, improvement of the vulval local hygiene, control of infective agent and allergen, diet modification, which should include low oxalates, psychological, TCA, gabapentin, biofeedback, behavioral treatment, surgery, vaginal laser vaporization of vestibuloplasty. Thank you.